The presenter is Dr. Avenado.
Good afternoon. I have no disclosure. Doctors Goldberger and Sandhu, colleagues, the title of my presentation is Do Improvements in LV Ejection Fraction Alter the Risk of Sudden Cardiac Arrest? Sudden cardiac arrest, or SCA, has a substantial annual incidence of 180,000 to 250,000 in the US. To reduce this incidence, risk stratification and prevention plays a critical role. Left ventricular systolic dysfunction is an established predictor for SCA, but recent studies have shown its limited utility for risk stratification in the community, since only a small proportion of SCA victims have severe LV systolic dysfunction. It is also known that a subset of patients with severe LV systolic dysfunction undergo improvement of LV function over time. How then will this affect the risk of future sudden cardiac arrest? To address this question, we analyzed temporal trends in LVEF among SCA cases and compared them to controls with coronary artery disease. The Oregon Sudden Unexpected Death, or Oregon SUDS, is an ongoing prospective population-based study conducted among approximately 1 million population in the Portland, Oregon metropolitan area. It has been ongoing since February 2002 and is now on its 11th year. This slide shows how we ascertain cases and enter them into the study. Presumed out-of-hospital sudden cardiac arrest are tracked from the community by first responders in 70% of cases, 25% by medical examiners, and 5% from hospital emergency rooms. After retrieval of clinical records and review of autopsy reports, in-house adjudication is performed to identify SCA cases. And for this, we have currently about more than 2,700 SCA cases. We study their epidemiology, and we perform detailed phenotyping. Their blood, DNA, and myocardial tissue are assembled into an archive. In parallel, we collect geographically matched control populations from same sources, and these controls have no history of cardiac arrest or lethal ventricular arrhythmias. We perform the same detailed phenotyping, and their blood samples and DNA are added to the archive as well. Subjects were entered into the study if they were 35 years and older. Cases and controls were required to have more than one echocardiogram at separate time points for comparison of ejection fraction over time, and for cases, they were required to have been prior to and unrelated to the sudden cardiac arrest event. We defined sudden cardiac arrest as a sudden pulseless condition of likely cardiac etiology, or if unwitnessed, it should be an unexpected death within 24 hours of being seen alive and in their usual state of health. We excluded cases that have non-cardiac etiologies, chronic terminal illness, trauma, and overdose. We defined the ejection fraction as normal if it was 55% or more, mild to moderate dysfunction if it was 36 to 54%, and severe if it was 35% or less. For the results, a total of 111 cases and 81 controls were entered into the study. As you can see here, the age were comparable, but cases had a higher percentage of males. This slide shows the distribution of LV systolic function at the first assessment for both cases and controls. For 44% of cases and 68% of controls initially had normal EF. 28% of cases and 21% of controls had moderate dysfunction, and 28% of cases and 11% of controls had severe dysfunction. This slide shows that cases were more likely to have worse systolic dysfunction compared to controls. This diagram shows LV systolic function changes over time as identified at the second assessment in cases. Of the 49 cases with initial normal EF, 36 stayed normal, 9 became moderately decreased, and 4 severely decreased. Of the 31 cases with initial mild to moderate dysfunction, 4 improved to normal, 22 remained the same, and 5 became severely decreased. Of the 31 cases with severe dysfunction initially, 11 improved, 4 to normal, 7 to moderately decreased, and 20 remained severely decreased. Presented in another way, these are still the changes in LV systolic function over time in 30% of SCA cases. The mean time interval was 24 months, an average of 24 months. So out of the 111 cases, there was no change in 78, 15 improved, and 18 worsened. Of the 49 cases with initial normal EF, 27% worsened. Of those with mild to moderate dysfunction, out of the 31, 13% improved and 16% worsened. And of the 31 with severe dysfunction, 11 or 35% improved, 4 to normal, and 7 to moderately decreased. As for the controls, this is a diagram which shows the changes in LV systolic function over time as identified at their second assessment. Of the 55 controls with initial normal EF, 40 remained normal, and 15 decreased, 13 to moderate, and 2 to severe. Of the 17 with mild to moderate dysfunction, 6 improved to normal, 8 remained the same, and 3 worsened. Of the initial 9 controls with severe dysfunction, 3 or 33% improved to normal, and 6 remained severe. Likewise, in a table, these are the changes over time in the 33% control. The mean time interval is similar to that of controls, 24 months. And of the 81 controls, no change in the ejection fraction was noted in 54, 9 improved, and 18 worsened. Of the 55 controls who initially had normal EF, 27% worsened, and of the 17 with mild to moderate dysfunction, 35% improved and 18% worsened. Of those who initially had severe dysfunction, out of the 9, 3 or 33% improved, which was quite similar to the 35% of cases. So for the conclusion, this analysis concludes that among patients with severe LV dysfunction, there is a distinct subgroup, about 1/3 of the group, which showed improvement and even normalization of LV systolic function over time, but yet continued to have increased SCA risk. Identical LVEF trends were identified in both groups, and these findings could have implications for clinical decision-making in ICD patients, especially at the time of generator replacement, which makes us think, once an ICD patient, always an ICD patient. Thank you for your attention.
Great, thank you. I was wondering how much of the change in EF or the lack of change in EF was attributed to the use of medications or revascularization?
Yeah, we actually looked into that, and out of the 11, let me see, we looked into that, and all our controls are coronary artery disease patients, and of those who improved significantly, there was about 11 of them who had intervention done, and of the cases, there were 7 that had intervention done on them.
What about in terms of medications?
We also looked into that. There was beta blockers in all of the people who improved over time. We particularly looked at beta blockers.
One important consideration is The problem with classifying people just with ejection fraction is, are we excluding those with significant mitral regurgitation? Because if there's a new onset of new mitral regurgitation, we'll overestimate the ejection fraction if just we take it as ejection fraction alone. So the function may be depressed, but MR falsely identifies it as an improved ejection fraction.
Yeah.
Was there any, I would say, thought given into this consideration?
We didn't look at mitral regurgitation per se. We only looked at the ejection fraction, but that's a good suggestion. We will look into that. Thank you.
Will Nicholson, Glenfield. Thank you. That's very interesting. It's addressing an important question. I'm wondering, echocardiograms, there's a substantial inter- and intra-operator variability in measurements over time. So how much of your findings could be simply that a different echo technician has measured a different ejection fraction? And could you control for that?
Yeah, that's a limitation of our study since we only retrieve medical records that has already been done. So that's a limitation of our study. Yeah.
Thank you.
Thank you.
What's fascinating is you mentioned that your controls were all coronary disease patients. Were your cases also coronary disease or all comers? Because we just looked at our definite study and looked at exactly the same thing, the effect of a change in ejection fraction. And when even those patients who had an improvement in ejection fraction, they had actually improved survival, but there was no difference in the incidence of appropriate shocks in that population. So a very similar kind of finding as in your population.
So for our controls, we have all of them have coronary artery disease, and we define them as 50% or more stenosis. And for the subjects, we have about like 80% of them with coronary artery disease.
Great. Well, thank you for those for that study.